and Dr. Don Johnson, a licensed psychologist and associate professor at the University of Akron. Before we get started, I would like to go over some of the technical details of the WebEx software that we will be using for today's webinar. Many of these details are explained on the Using this Webinar System tab on the upper left-hand side of your screen. Please be aware that your screen might look a little different depending on whether you're using a Mac or PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with trainers or myself if you have questions regarding the training content. You may contact Angelica Medina also at the center if you have questions troubleshooting the WebEx software. To do this, click on the down-facing arrow and select the person you would like to contact. You will see a lot of options, but for this session, you will want to select all participants if you would like to respond to a question from the trainer or to contact me anytime during the session. You should click on Angelica Medina to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, type in where you're calling from, and then press enter. Perfect. Thank you so much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. I will be moderating a question and answer session at the end, time permitting. And at the very end of the webinar, you will be taken to a brief evaluation. Please take a moment and let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call in if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Angelica Medina, you may call WebEx Tech Support to resolve any issues. That phone number, which we will also put in the chat box, is 1-866-229-3239. Again, thank you for joining us today, and I will now turn it over to Carole.
Thanks, Carla, and thanks, Angelica. So we're delighted to host this webinar today by Dr. Don Johnson on HOPE, Helping to Overcome PTSD Through Empowerment, which is her cognitive behavioral therapy and empowerment-based treatment that was specifically designed for women in domestic violence shelters who are experiencing IPV-related post-traumatic stress disorder, PTSD. This webinar is part of the National Center on Domestic Violence, Trauma, and Mental Health's ongoing series on trauma-focused interventions for survivors of domestic violence. Dr. Johnson will talk today about how HOPE was developed, what HOPE entails, what's actually involved in the intervention, and what's involved in its implementation, like how do you do it. She'll also present her research findings on the feasibility and efficacy of HOPE, as well as some of her new research on HOPE's more recent iterations. Part of what's really exciting about Dr. Johnson's work is that she keeps learning from, from survivors and advocates and what's helpful and what's not, and keeps developing new iterations of it to be responsive to the needs and what she's learning about survivors. Dr. Johnson and her important work are also part of a larger NCDV-TMH initiative to identify evidence-based, evidence-informed, and promising approaches to healing from trauma in the context of domestic violence. Let me just move this slide forward. and to consider their relevance and applicability for survivors from a range of cultures, communities, and circumstances with a range of identities, and to develop recommendations for the field regarding their implementation and possibly evaluation if that's an issue. So one very exciting part of this project is our soon-to-be-launched online repository of trauma-focused interventions for survivors of domestic violence. That's going to provide an easy-to-access summary of information about each intervention from both the published literature and from interviews with the authors and developers, and Dawn's will be one of the first ones that we feature. So we're very excited about that. There are many aspects of HOPE that we find very compelling, but I'm going to leave those to Dr. Johnson to talk with you about. We'll be doing this in a Q&A style, but please type in your questions, and Dr. Johnson will respond to them at the end. Dawn?
Well, thank you, Carole, for having me, and for everyone who is attending. I'm excited to talk about my research and HOPE and the development of HOPE over the last 15 years.
So do you want to control the slide progression?
Yeah, I can do that.
Okay. So Dawn, can you talk a little bit about what your rationale was in developing HOPE and why you thought it was important to offer a PTSD treatment in a shelter setting specifically?
Sure. You know, it's a really good question. A lot of people throughout the years have asked me if it might be premature to really offer treatment to this group of women who are currently in a state of crisis. So here's a little bit about where my thinking was as I started this process. First off, we know that shelters are a very important resource for women who experience intimate partner violence. They're widely available throughout the United States, and a recent survey showed that just last year, 41,195 victims found refuge in a shelter in a single day. And we know that shelters are an integral resource for providing support and case management and advocacy for survivors. We also know that when women come into shelter, they've initiated a change in their life. They're looking for something to change. And so that might actually be a prime time to intervene. They're ready. It's also a safe and supportive environment for women, which is not necessarily the case previously to them coming to shelter. And although in recent years I've seen many more shelters begin to offer counseling services, still many shelters don't have the resources or the ability to offer treatment specifically targeting PTSD. So in focusing specifically on post-traumatic stress symptoms, one of the things that has become apparent in the literature is that the PTSD symptoms that women experience from the violence can actually interfere or negatively impact their ability to do what they need to do while they're in shelter. And what research finds is that especially the numbing and the arousal symptoms can interfere with women's ability to access and effectively use resources. And that can ultimately impact their safety. So in designing HOPE, we really were focusing on trying to break that cycle and address the PTSD symptoms in a manner that will help them maximize the use of resources while they're in shelter.
So that all makes a lot of sense, and I'm really glad you were able to talk about that. So given that, what are some of the things that you thought were really important to consider in actually offering HOPE in a shelter setting?
That's a really good question, because I think anyone who's worked in a shelter knows it's a pretty unique setting. And there were a lot of things when we first started this that we really had to think about. First off, one of the primary considerations of women in shelter is safety. So anything we did had to put at kind of the forefront women's safety, both in treatment and when considering how we go about treatment. Also, many women in shelters don't necessarily have easy access to transportation. So that was where the decision came in, both for safety reasons and for transportation. If we go into the shelter and provide the counseling where they're at in a safe environment without them having to leave and go elsewhere would be maximize their safety and address the transportation issues. One of the other things that we found is that women in shelter have multiple competing demands. They have many things they're trying to accomplish, and many of these things may be their main priority: finding housing, finding employment, dealing with changing in kids' schools. So that really requires a therapist to be flexible. The traditional 9-to-5 work schedule didn't necessarily work with this population, so that required us sometimes to do early morning sessions, evening sessions, and sometimes even weekend sessions. The other thing that we thought was really important is to provide childcare for women while they're being seen in sessions. So childcare was always available for women. And we also thought it was important, since most shelters and all the shelters that we've worked with usually provide some kind of case management and have a case plan for women, that we really wanted to coordinate with the shelter and target our treatment program so that we're actually working with their goals in shelter and their case plan. A caution that we found that we had to really think about it on the case plan side of things is that sometimes we would find case managers to want to put attending hope on the case plan, and we found that to be potentially coercive. So it was also important for us to work with shelter staff around encouraging people to participate but not requiring it. And I think one of the hugest considerations that we had to really think about was confidentiality. And although over the years this has changed to the point of how much substance use is restricted in women and contact with the abuser and the rules that shelters have, but we wanted to make sure that anything women shared with us in our counseling sessions was confidential and wasn't something, and make sure the women knew that we weren't going to be communicating that to shelter staff. So if they were using substances, that wasn't something we were going to tell the staff, unless anything was to the point where it was a danger to themselves, if they were suicidal, or to other residents in the shelter.
So before I go on to the next question, I just wanted to say I'm really glad, Dawn, that you raised the issue around voluntary services, which is really critical for domestic violence services, and the SIPSA regulations that you can't require participation in any services or treatment. So I'm really glad that was something you were thinking about way back when you started this,
right.
And also the confidentiality issues, which are really critical. It's interesting because those are a lot of the concerns that would come up if someone was seeking treatment outside that wouldn't necessarily be addressed, that are so critical. So, okay, so the next question I have was, like, how did you develop HOPE? What was the kind of theoretical or conceptual underpinnings that led you to put things together in the way that you did?
Sure. Well, we started really focusing on a cognitive behavioral and an empowerment approach. And we developed HOPE through a series of research studies, which I'm going to talk about throughout this presentation. Our starting point was the literature. And we started with the literature on cognitive theory and treatment of severe trauma, treatment of IPV survivors, and treatment of PTSD. And what we thought really fit best for this population was Herman's multi-stage model of recovery. And if you're familiar with Herman's model, she hypothesizes 3 stages of recovery, with the first stage really focusing on establishing safety. As you see, I have that starred multiple times, because I think that's the stage that women in shelter are at. They're early in recovery. Their focus is on stabilization, emphasizing goals of safety and empowerment. The later stages are really things that happen after women leave shelter. Traditional PTSD treatment, for example, fits where women would re-experience or be exposed to traumatic memories, fits more within the second stage, which I don't think women in shelter are necessarily ready for. So we really wanted to focus on this first stage presence-centered model. And then the other thing we wanted to incorporate was an empowerment model. And we drew upon the literature of Judith Worrell and Pam Reamer and their book on feminist therapy, and incorporated a lot of their empowerment principles. And this translated into really focusing on increasing choice and control in a group of women who really haven't had experienced any sense of control in a very long time. And so we started with the literature and developed a preliminary manual. And HOPE actually started as a group in our first iteration. And then we tried that and got feedback from women that they have a lot of group types of activities within shelter, but less one-on-one time, and they really asked for an individual treatment, which is why HOPE is an individual treatment today. And then we did 2 studies, which I'm going to talk about shortly. The first, we started with HOPE as a shelter-based program, where women received HOPE exclusively in shelter. We were trying to mirror what typically happens in shelter settings, where women receive services in shelter and then are referred out to services in the community after they leave. And we really tried to involve our population in the development of the treatment. So we always started with focus groups, and we would get feedback from women who were currently in shelter. And then we did a small pilot randomized clinical trial testing that treatment. And then based on those results, we did it again and expanded the treatment to include post-shelter sessions and went through a very similar process again. So that's the that was our process. We started with theory, and then, as you said before, we let the research kind of guide us, and the feedback from shelter residents and women who participated in the therapy to guide us to get to what HOPE looks like today.
Great. It's a wonderful combination of kind of thinking about what works from the clinical side and really listening to women about their experiences and what's important to them. So, okay, so the next part is, what are the primary components of HOPE? What's actually involved in implementing HOPE, or not in implementing, but in the intervention itself?
Sure. HOPE has multiple components, and I'm going to kind of highlight what are some of the main components. And I think the thing that guides HOPE is what I call the HOPE hierarchy. And basically, if anyone's familiar with dialectical behavior therapy, Marsha Linehan has a hierarchy of target behaviors. And I was kind of borrowing on that sense of what do we want to prioritize? And this hierarchy guides what happens within a session as well as across sessions. What do we prioritize? So we use that both in designing, like what we address when across therapy, but also what do we prioritize within a session. And what we start with is immediate physical and emotional risk. So safety, anything that's interfering with their physical safety or their emotional safety takes priority. And then if there are no immediate physical or emotional risks, then we move on to the PTSD symptoms that may interfere with their ability to do what they need to do. So to meet their shelter goals or to meet the treatment goals that they worked with us to develop in HOPE. So we focus on those symptoms that are most problematic for them and getting in their way. And once we address those, then we focus on the symptoms that are less interfering with their goals, but still interfering with their quality of life. And then last, we focus on their post-shelter goals and safety. So in the original version of HOPE, we're all in shelter, and at the end of treatment, we really focus on, okay, what do you do? How do you take this with you when you leave shelter? So this hierarchy drives both what happens within a session and how we individualize the treatment program specifically to meet the woman's needs. Every session also has a structure. We try to meet twice a week as often as possible. That wasn't always possible, but at least once a week. And then we would always start every session checking in around safety. Safety always took priority. And then once they were in the therapy, we would check in on what we call in HOPE accomplishments. So in CBT, we usually call this homework, but I don't like the connotation that often comes with homework, so we really emphasized what do they want to accomplish between sessions, or what do they want to accomplish and what are their goals for the next period of time. So at the end of every session, we kind of negotiate with them, what's a reasonable goal, what's something you want to accomplish, and we always follow up with them on the next session. And every module we have has a quote that demonstrates the construct that we're going to be talking about, whether it's safety or empowerment, and we usually use that quote to introduce the module and introduce like the theme for the day that we're going to be talking about. And then the session focuses on whatever the content of that module for the day and ends with the collaboration, with collaboratively negotiating accomplishments between sessions. Another core component of HOPE is what we call the Empowerment Toolbox. And the Empowerment Toolbox is something that it's like a very long list of potential tools that they can use to manage their symptoms, to empower themselves, and to address relationships. They're healthy coping skills. And throughout HOPE, we zone in on many of those empowerment tools, but they start with the big list and they go through and identify which skills they're already using, which skills they think they could use more, which skills they need to learn more about that they're not sure how to use. And then every session, everything goes back to this toolbox. And the toolbox focuses on 3 different kinds of tools, and they're divided into these 3 sections. The first is establishing safety and empowerment. These include things like inspire yourself, watching for red flags for abuse, or don't spin your wheels, which is getting at the idea of if it's not working, don't keep doing it, try something new, different. There's a list of tools to help them manage their PTSD symptoms, such as self-soothing, rethinking, which is what we call cognitive restructuring, or stop the thought, which is getting at kind of interrupting or stopping any negative thinking. And then we have tools for improving relationships. A lot of these are around assertiveness, like setting boundaries or asking for help, or trust. So we have a module on kind of how to learn how to trust, who to give trust to, the fact that trust has to be earned and that you give a little bit of trust at a time in lower risk situations and not all trust all at once to one person. So the toolbox is introduced early on in like session 1 and then used throughout treatment. Now, as I said before, and I've referred to modules, the way HOPE is set up is there are different modules. So where some manualized approaches are session 1, you do this, session 2, you do this, session 3, you do that. HOPE is set up so that there are different modules and you can tailor the order to the individual's needs. The order that they're provided in the manual make intuitive sense, and oftentimes we do it exactly in that order. But when I talked about the HOPE hierarchy, we can use the hierarchy to order the sessions. So for example, if you have someone who is just having horrible nightmares and can't sleep and is having a lot of problems sleeping, and they're waking up in the morning and they're so tired and they just can't get themselves going to do the things they need to do, like go apply for jobs or look for housing, then we might prioritize and move up earlier the skills where we talk about safe sleep and sleep hygiene. So that might come earlier. So we can really tailor and just move the modules to the individual's needs. The modules are divided up into to kind of match with the empowerment tools. The first set of modules all focus on establishing safety and empowerment. So we have a module on goal setting, a module, and this is where we really collaborate and talk about their goals for treatment, and we help them see how the things we're going to do are going to work towards their goals. So we really focus on helping them see and make connections between what we're going to do in counseling and what their individual goals are. We have a module that really focuses on the psychoeducation around PTSD and abuse and what PTSD is, and women often find this very empowering because they're often experiencing things that they don't really understand, and to have a label and to normalize it as common reaction to being traumatized is it can be very validating for them. We also have a module on safety planning that we usually do really early on, and then we incorporate safety planning throughout and always kind of follow up on their safety plan and modify and adapt as necessary throughout sessions. We have a module on empowering yourself where we talk a lot about power and control and ways that you can give and take power in positive and negative ways. We go through the power and control wheels, which most people who work in the field have some familiarity with. And we really kind of work on helping women see where they do have control, even in a situation where they don't have a lot of control, but what parts of the situation are under their control. And then we have a module on establishing trust in relationships, which I talked a little bit about when we talked about the empowerment toolbox. The next set of modules all focus on managing PTSD with empowerment tools. So this is kind of the traditional CBT skills-oriented part of HOPE. We have a module on what we call rethinking, which is a cognitive restructuring model, where we teach women to challenge any thoughts that might be coming from the abuse or from the PTSD, and how to rework those into what we label surviving thinking or empowered thinking. We have a module on coping with triggers, identifying triggers that trigger their symptoms of PTSD, determining whether or not these triggers are safe or unsafe, because, of course, many of these women, there are triggers in their lives that are unsafe, and avoiding is a good thing, or if they're safe triggers and things that they can gradually approach and learn to manage and deal with better. We have a module on safe sleep, which I alluded to earlier, where we go through ways to make the sleeping environment safe. Often this is coming from the PTSD symptoms interfering with their sleep, but sometimes it's also in a shelter environment. That environment may be interfering with their ability to sleep, so we talk about good sleep hygiene and how to maximize and get the best sleep they can in that environment. And we also have a module on self-soothing and relaxation, where we emphasize the need to take care of oneself, include pleasant activities to help manage their emotions. We have relaxation exercises and visual imagery, and we usually provide CDs or audio files for women who have access to listen to these when they leave shelter. And then our final group of modules is on improving relationships, and this is traditional CBT with an empowerment focused around assertiveness and establishing boundaries. So we have a module on really talking about boundaries and what they are and how to set them and what their rights are and how to assert those rights. We have a module on safe and healthy relationships, helping them identify what is a safe and healthy relationship, what should it look like. And we also have a module on managing anger, as we know that women are often socialized to not express their anger, so we have a lot of women who are either stuffing their anger and not finding a healthy way to express it, or if the PTSD takes over, the anger may become explosive for them and they need to find ways to more healthily manage that anger. As I said, we try to individualize treatment as much as possible, so HOPE also has a bunch of optional modules that we can integrate throughout treatment when necessary. So we have a module specifically for dealing with crises because usually women will come up with a crisis, and so we have kind of a strategy on how to address crisis within session. We also have a module when there's comorbid substance abuse, and this is a unique module in that it's not just a session thing that you do, it's more of how to integrate substance use and the interplay between substance use and PTSD throughout the whole program. For women who might have substantial dissociation symptoms, we have a module on grounding to help deal with dissociative experiences. We have a module on managing nightmares, which often can get integrated in the sleep module for women who have nightmares as an issue for them. And we also have an optional module on grief for women who are having a particularly hard time with the loss of the relationship with the abuser. So that's where we started with the shelter version of HOPE.
So, and I mean, you incorporated so many different components that come up for people who are struggling with trauma, and tailored it to the context of people who are dealing with an abusive partner or abusive relationship. And so it's really nice to have all of those components together. Some of the things that we've thought about are like, how do you deal with ongoing risk and safety? How do you deal with multiple experiences of trauma, which the kind of Judy Herman's model is really designed to do. So one of the things and the other piece is being able to manage the tension between doing a randomized controlled trial and having a manualized treatment, which is often how that works, with being able to be flexible and adapting modules to the specific needs that people bring, which is really nice. So, okay, so the next part is presenting your research and findings. So what did you find about how effective HOPE is in the shelter setting?
Okay, so we started with a randomized trial of 70 women who were all, and in this shelter, women were all in one of two shelters in the same shelter system. And we had 35 women who got HOPE. And the way we did this is, of course, everyone's in shelter and they get what we call standard shelter services. So they get all the therapeutic case management aspects of shelter. And then the women who got HOPE kind of got that plus HOPE. And we compared them, and that was randomly determined. And treatment occurred only while women were in shelter, and then we followed them up 1 week after they left shelter, 3 months after they left shelter, and 6 months after they left shelter. Because this was a research study, we had to be real clear on who we were targeting. So our inclusion criteria was that women had to have either PTSD or subthreshold PTSD from the intimate partner violence. And we added subthreshold PTSD because a lot of literature is showing that even subthreshold symptoms of PTSD can be very problematic for women. Again, since HOPE is really focused on women who have safety concerns and have recently just left a relationship or are potentially still have one foot in a relationship, we wanted the abuse to be recent to their shelter admission, so all women have abuse in the month prior to coming to shelter. Because it was a study, we had to make sure that they were stable on any medication if they were on any psychotropic medication, and that they weren't receiving any other kind of therapy. And also because women with bipolar disorder or psychosis or imminent suicidal ideation and intent might need something different than HOPE, we didn't include them because we wanted people, we didn't think what we were providing would be sufficient. We wanted them to get those resources from the community. So this was actually, we were very surprised. We retained 93% of participants at 6-month follow-up, so we had an excellent follow-up rate. The women who participated were relatively young, mean age 32 and a half, and as is pretty consistent with the shelters that we were working with, our population was about 50% African American and 50% white. So we had very few women from other ethnicities represented. Most were living with or married to their partner prior to coming to shelter, and most women were low SES receiving some kind of public assistance. So what did we find? First thing we were interested in shelter, can you get a significant dose of the program? How many sessions did they actually receive? And we found that women had attended on average around 7 sessions, so a little over half of the available sessions to them, because the original version of HOPE was 12 sessions. So a good amount of therapy, but clearly not a majority of the program. We had them rate early on after we gave the rationale for the program and kind of described and laid out for women what we were doing, the credibility. They found the program to be relatively credible, 6.78 on a 9-point scale. And after completing treatment, we looked at their satisfaction, and they rated their satisfaction with a variety of components, and the average was 3.4 on a 4-point scale. So women were finding the treatment acceptable and were satisfied with the services that they got. Then we looked at what happens on the outcomes we were trying to hit. And of course, first we were looking at PTSD. And this slide is looking at women who had, percentage of women who had either PTSD or subthreshold PTSD at follow-up. And the pink group is the control, purple is HOPE. So the control group, the trend had higher rates of PTSD than the people who received HOPE. The only time point where that was actually significant was at 3 months. So we were finding a trend towards the difference in diagnostic status, but not necessarily a significant difference at each time point. When you look at PTSD more continuously as a severity score, and we use the clinician-administered PTSD scale, or the CAPS, we had a trend. Clearly, you can see that the controls are higher, have more severe symptoms, the women who did not receive HOPE, but that wasn't statistically significant. However, we did have a lot of clinically significant and statistically significant findings. Our most impressive finding, I think, was percentage of women who experienced re-abuse after they left shelter. And you find that the women who received HOPE had fewer experiences of incidences of re-abuse relative to controls. So that's getting at the idea that perhaps if we deal with the PTSD, that maybe they are better able to access the resources they need to establish safety and really benefit from shelter. We also found a significant difference on depression, in that women who received HOPE had less severe depression symptoms after leaving shelter relative to those who did not receive HOPE. And we also found increases in empowerment. So women who received HOPE scored higher on empowerment after they left shelter at each follow-up point relative to those who did not. So what does this tell us? This tells us that there's some evidence that's feasible to engage shelter residents in PTSD treatment, and there's some evidence that perhaps it helps them in some way. There's some evidence that there's some efficacy. They find it acceptable, they have high satisfaction. We didn't find exactly what we wanted on PTSD, but there were some trends in that direction. And if you break PTSD down by the clusters, you do find that some clusters are significantly reducing in the HOPE group. Women in HOPE are less likely to be re-victimized, have less severe depression, less severe, are more empowered, and we also found more social support. However, what we did also find is that many women still experience significant PTSD symptoms after they leave shelter. They're still pretty high, and many women still have the subthreshold or full-blown PTSD. And a large percentage of women experience re-victimization after they leave shelter. And we also know that a large percentage of women didn't really receive the whole program, or even, and most women only received about half the program, so they're not really getting the full dose, for out of lack of a better word. So that led us to think maybe it's a good idea to start treatment in the shelter, but that's not enough. And we also found that as women leave shelter, they also lose the support, and oftentimes, naturalistically, you just find this increase in symptoms in women because they're leaving that really safe, supportive environment. So we thought that that required us to really expand HOPE to continue after they leave shelter. So that's kind of what we did next.
Yeah, so this leads into the, talking about the kinds of changes you made based on your research findings. And I think one of the things that you pointed out, that because the PTSD components were later in the intervention, a lot of people didn't get that part or enough of that part necessarily to make a difference in their PTSD. Yeah.
Right. So what we did to expand HOPE after they left shelter is we ended up, and these were based on some focus groups and talking to a lot of women, is having a 3-month period where we expanded treatment to continue. And in the revised version of HOPE, or HOPE 2 is what I usually call it, we added further safety planning and risk analysis, specifically targeting post-shelter, because everything changes after they leave. That safety plan needs to be modified. And also, based on focus group findings, women really said one thing we had in shelter was the supportive groups. So as I said before with HOPE, they said they didn't want HOPE to be a group when they were in shelter because they were getting all these groups. Women were noting after they left shelter, they no longer often had those groups. They didn't have the supportive milieu environment, and that they would like to have something where they could be with other women and get that support from other women in the same experience as them. So we added a monthly group post-shelter that kind of focused on case management and support. It's in red because, as you will find, there were some problems with this component of the treatment, and I'll talk about a little bit later. We also expanded the treatment to really focus on refining the shelter case management plan after they leave shelter. We added some booster sessions to really help them kind of review and apply, and how do we use these skills now that we're outside of shelter. We boosted the crisis management component, really focused on an application of the skills in real-life situations. And because research was continuously coming out emphasizing how avoidance and emotional numbing symptoms were most related to re-victimization, we also boosted our component on that. So the new version of HOPE added this post-shelter component, and it added modules that were specifically designed to happen after women leave shelter. So women will go through the treatment in shelter for as long as they were, and the one thing that is very unique, I think, about this population and about HOPE is we could have some women have like 10 sessions. They could have up to 10 sessions when they were in shelter and 6 sessions after they leave shelter. And then we could have some women who get all 16 sessions after they leave if they, you know, get with us, get enrolled in the study, and then leave the shelter the next day. So where there was a lot of flexibility in where they received treatment based on how long they actually stayed in shelter. But as soon as they left shelter, we had to redo their goals because their goals would be very different at that time. And we also, many women don't continue to get case management after they leave shelter, but still have a lot of case management needs. So unless women were involved with another agency or still had access to case management, if they had that, we let the case manager do it and kind of coordinated with them the same way that we did while they were in shelter. If they didn't have that, we integrated it in. We updated their case management plan and integrated that throughout the rest of the sessions. We boosted the safety planning and really evaluating what's changed now that you're outside of shelter. We added 2 sessions that are specifically reviews or booster sessions where the client really gets to choose what skills they want to kind of go over again, and then we really talk through how can you use this, how can this be integrated into your life, what works for you, what doesn't. So it's very applied to their current situation. And then we added a final termination session, which really kind of worked on, okay, what now and how do I carry this forward after we finish therapy? Because really, HOPE's about giving them skills and teaching them tools that they should be able to continue using long after therapy ends. We also added some additional optional modules. So the 2 new optional modules are the ones depicted in red. We had the same modules from the original version of HOPE, and then we added optional modules on emotional numbing for women who really had a lot of numbing symptoms and zoomed in on those and skills to manage those. And also just based on feedback during the focus groups, we added a module on co-parenting with the abuser. Because we were finding that a lot of women, as they get out of shelter, one of the biggest struggles they have is how to manage their safety and their emotional reactions when they're co-parenting, and really coming up with how to do that in the safest way for them, both physically and emotionally.
So, given all the changes you made in developing this new post-shelter iteration, did that result in improved outcomes for women?
The short answer is yes. We do find some better outcomes, and let me show you exactly what we found. So we did another randomized clinical trial, and this one, same model as before. Everyone was in shelter and got what therapeutic services shelter had to offer, and then 30 women also got HOPE on top of that. Inclusion criteria are the same, except for we did add an exclusion criteria of substance dependence in the last month. Primarily because although we do address the comorbidity between PTSD and substance use, and we have the module, it's not a focus of treatment, and this group is such high risk for relapse that, and many need detox and other things that we thought that they really needed something more than what we were offering. The other different thing about this study is we were on a bit of a shorter timeline, so we involved more shelters. So we were at 4 different shelters in 3 local counties, and we followed this group for 6 months after they finished treatment. But since treatment extended 3 months after they left shelter, we were following them for 9 months after they left shelter. So our retention was a little more challenging because it was a longer period of time, but still respectable, as you will see that the retention numbers are left are HOPE and right are people randomized to control who didn't receive HOPE. And we had a little harder time keeping track of the women who didn't receive services from us, which makes sense and is typical. And all the analysis that I'm going to report include everyone regardless of how many sessions they attended. Similar demographics to the first study, a young sample, primarily African American and white, almost all living with abuser, most have children. We do find consistently that from these shelters, they're relatively educated. 60% had a high school diploma or a GED. Most are unemployed, most on public assistance, almost all low SES. So the first question is, our goal was to get them more sessions, right? So we expanded treatment in hopes that they'd actually be able to get more of the sessions available to them. And if women on average had about 5-6 sessions in shelter and about 6 to 7 sessions after they left shelter, so about 12 to 13 of the 16 sessions available to them, which is pretty respectable and pretty consistent with what we see in other research. So I think that shows, yes, we got where women before had on average 7 sessions, now they have almost twice as much of that. So they're getting more sessions. So expanding treatment gave us that. But as you see here in red, I have that most people didn't attend that group. So although women asked for that group, and when we talk to women, women are like, I really want to go. Logistically, it was a nightmare. Finding a time, especially with a small number of women, that worked for everyone, and we were in 4 different shelters, and so there was a lot of finding a location that worked for everyone was very challenging. So this group component just kind of didn't work in this setting, and has since we've removed it from HOPE, it didn't stay because it just didn't work. And our satisfaction ratings are a little higher than we had before, still pretty high, 3.8 on the 4-point scale. So it's looking like we can keep going with the therapy, that's acceptable and feasible, and that women were satisfied with the services that they received. And this slide shows, kind of similar to the first slide I showed for the first study on HOPE, percentage of women who met PTSD or subthreshold PTSD. And at 6 months, you see we have a pretty large difference in that the control has over half the women still have PTSD or subthreshold PTSD, where a much smaller percentage of women in HOPE still have clinically significant PTSD symptoms. Similarly, if you look at PTSD at a continuous, the severity of symptoms, we find a significant effect where the women who received HOPE have significantly less severe PTSD symptoms across follow-up. So this is really a positive finding in that, and Carole mentioned that the PTSD components of HOPE are really towards the end, and now women are getting more of that by expanding the treatment, and now we see a bit of a stronger effect for PTSD symptoms. Yet, surprisingly, we didn't find the same thing with abuse in that we found no significant difference between HOPE and the people who didn't receive HOPE on the severity of abuse that they experienced after leaving shelter. And we looked at this severity, and we looked at this similar to how we did in the other story of kind of rates of re-victimization, and the findings are all pretty similar. And one difference between the first study and the second study is that in between, the economy collapsed. And one hypothesis we have is that because of the changes in the economy and the more higher difficulty in getting jobs and housing, most of our shelters were allowing women to stay longer. So women were actually staying in shelter a lot longer in the second study than they were in the first study. And some of my research shows that length of shelter stay is also related to reabuse. They're able to get more resources, they're able to get into a better place before leaving shelter. So one hypothesis is that that kind of washed out any findings because they got what they needed from shelter. But we find similar findings as in HOPE 1 in empowerment, where women who received HOPE had higher empowerment at follow-up relative to those who didn't. And we also had many other similar findings related to depression and social support, and that were consistent with HOPE 1. So what this study tells us is that we can start treatment in shelter and keep it going, that was feasible and we could make it work. It also provides some initial evidence for the efficacy of this expanded version of HOPE. Clearly, the group component was not feasible and was just not going to work, so we removed that. And then the next thing would really be to do this on a larger scale and really kind of have a more robust control condition and attention match control to look at HOPE to really understand if it's something specific to HOPE that makes it efficacious or if it's just good therapy.
So that leads us to what are you doing now in relation to HOPE? What's your new research and your new thinking?
Well, we just finished a large randomized clinical trial of HOPE, kind of getting at what I said the next steps were before. So what we just finished is a study comparing HOPE to something called presence-centered therapy. And presence-centered therapy, it was basically designed to be a control condition in PTSD research, but it's designed specifically to control for all the non-specific factors of therapy, the relationship factors that are hypothesized to be, in all types of therapy, so kind of the common factors of therapy. And at the time that we designed this study, presence-centered therapy was not on the list of empirically supported treatments for PTSD, but since we have found that many studies have found PCT, or presence-centered therapy, to really be effective in treating PTSD. So it's a pretty robust control condition that really does well at treating PTSD. The other thing we really tried to do is focus with an eye towards dissemination. So where in the past I've done some of the therapy, or other PhDs or doctoral students or postdocs, we really wanted to train and see if we could have therapists in the community, master's level therapists, deliver the treatment. So I partnered with 2 community agencies, and they provided the 4th therapist, who were all master's level therapists for the study. And we also wanted to really look at a wide range of shelter settings. So we worked in 8 shelters in 6 counties. So we were pretty much driving within a 60-mile radius of Akron, Ohio. And then we also wanted to really focus in on durability of findings and expand our longitudinal follow-up. So we followed women for a year after they finished treatment, which, since treatment continues for 3 months after they leave shelter, is 15 months after they leave shelter. So we had a total of 172 participants in this study. Now, we're still doing analysis, and we're trying to build some kind of complicated models to adjust for all the different ways the HOPE can be delivered based on how long women stay in shelter. but it's just some preliminary analysis. We do find some trends that favor hope. So this is looking at the percentage of women who still have a full-blown PTSD at follow-up, and we do have a difference at the year follow-up in that women in hope were less likely to still have PTSD relative to women in PCT. And we also do find an interaction between the therapy that they received and their violence severity after shelter. And most of this is happening specifically at post-shelter. The levels are pretty similar of violence after women finish treatment, but in that period during treatment between when they were in shelter and left shelter, there's a substantial difference between the severity of violence. So that might be something going on in the shelter portions of the treatment that might be having some effect on the violence women experience after they leave. So those, like I said, we're still evaluating the therapy, but some preliminary findings that show that PCT and HOPE, I think both do a good job, and what we need to do is tease out, are there things that HOPE does better than PCT, and are there people who benefit more from HOPE than PCT?
Great. I mean, it's hard when the control condition is actually an effective treatment for some of the same things you're trying to study. So what about if you wanted to provide hope to domestic violence survivors who aren't in shelter, just starting out from not being in shelter?
Mm-hmm. I get that question a lot, and I think hope is really easily adaptable to be delivered outside of shelter. That's the population that I think hope is specific to is women who are either still in the relationship or just recently left an abusive relationship. So this isn't really a program for women who've been out of a relationship for a year or two. But if they're still being abused, experienced abuse, or just trying to get out or recently out, it's pretty easily adaptable. So we've used this in women who are in a relationship that is abusive, but they're not ready to go to shelter, where we really focus on the early stages and helping them make a decision around do they want to leave the relationship or not? Is shelter a good decision for them? I think it's easily adaptable to women who choose not to go to shelter for whatever reason, either because they have other resources and can stay with friends or family, or because they just decide that a domestic violence shelter isn't a good fit for them. I think it's easily adaptable to women in transitional housing or homeless shelters or other kind of settings like that where they have similar needs. And again, women who are just recently left their abuser and still face the ongoing risks that we see in women in shelter.
And, you know, I think that's a really important point that we didn't make earlier, that some of the earlier interventions, when you said you reviewed the literature on PTSD treatment for survivors of IPV, was that a lot of earlier models were designed for people who no longer had contact with an abusive partner and not for women or survivors in general who are at ongoing risk. And so that's one of the things I know that you considered in developing HOPE, which I think is really important, because even if people do leave, they're likely to be at risk for quite some time, or maybe for indefinitely. So what are some of the next steps for HOPE? Oh, and I have some other questions, but let's talk about that, and then I'll ask you a few other things.
Okay. So next steps. As we're focusing right now on analyzing the results and kind of writing up and figuring out the results from the randomized clinical trial that we just finished. But if we find what we hope to find and we can find some evidence of efficacy over and above what we find in PCT, the next step is dissemination and really figuring out how best to do that, and looking at how HOPE might need to be adapted in different kinds of environments. Also cultural adaptations. As you saw, most of my work has been with women who are English speaking and either white or African American. We haven't had a lot of Hispanic, Latina women or other cultures. So work will need to be done to see what we need to modify in delivering in different settings and different cultures. I also think, and I alluded to this before, is anecdotally, I think there's some people who might do better with hope than other people. And who are those people? Like who's the best population to target with this program? And something else I've talked to a lot of people about is cost effectiveness and the accessibility of hope, and is there a way to adapt it to be delivered by advocates? Because hope as it is now is really designed to be delivered by trained clinicians with at least a master's. So I think it's worth trying to see, can we adapt this in a way that would make it more accessible to a lot of women in shelter.
Great. So now we're going to open up to questions from all of you who've been participating. I know, Brenda, you had a question. Carla, were you going to read Brenda's question, or do you want me to? I'll do it. This is from Brenda Hill in South Dakota. Hi, Brenda. You mentioned you had a few concerns, and you wanted to know what standard shelter means, given the advocacy field has changed in the last decade. And there's a tendency to do more service provision instead of women-centered advocacy. Have the advocates gotten trauma-informed approaches training? Also, is there time given for women to rest and heal and sleep and deal with sleep deprivation, vitamin deficiencies, TBI, et cetera, before entering hope? And she said, Brenda, you said you're trying to envision this as in rural areas and tribal lands, and that many programs still have extreme time limits for women to deal with criminal justice, custody, moving schools, et cetera, overwhelming kinds of things that people have to deal with in their lives. So it's a lot of questions in one question, but I know that many of these things are things you will have thought about. So.
Yeah, and they're good questions, and I think, you know, within the research I've done, standard shelter services was what was standard for that shelter, and that did change over time. And I know the shelter that I worked with the most closely, that all of the first study was in, and a large percentage of the participants in the second study were from the shelter that's most local to me, that I work most closely with, and as well as in my most recent research, they've changed their model of standard shelter services throughout the time that I've worked with them. So their advocacy models have changed. They have moved to more trauma-informed models. I know that, you know, there have been changes about requiring, Carole, you alluded to requiring shelter residents to partake in certain services, where when I started this work, case management was required and every woman had a case plan, where now that's something that case management is an option, and although most women just choose to participate in case management and have a case manager, some don't. So that's been variable. From a research perspective, it's the same across all participants at the same period of time, but it's definitely been variable over time. And it's unique to every shelter setting, so different shelters did things differently, and that's one of the things that in our most recent study, where we've looked at 8 different shelters, some of those shelters provided a lot more service. Some of the shelters were smaller and had fewer staff and provided a lot less service. For example, we have one shelter that was very unique to me that's in a more rural area, and it wasn't staffed 24 hours a day, and women's had keys to their room and to their shelter, and it was a very different environment than many of the other shelters that we were in. So there's a lot of variability in what we call standard shelter services. So that was kind of the first question. And then there was another one about like taking to whether women were given kind of time before doing HOPE. So participation in HOPE happened when women chose to do it. So we've had women who might say, yeah, this is something I want to do really early on, and we've had women who are like, no, I'm not ready for that, and then after being in shelter for a few weeks, contact us and say they want to do it. So we did not restrict it so that like we were asking them day one and they had to decide then. Women kind of came to us and said this is something they want to do based on when they were ready. And we also, when women contacted us, we spent a lot of time saying this is what basically HOPE is and what's going to happen, and spent a lot of time making sure that this was something that they really wanted to do before going to the next step. So there was a lot of diversity on how long women were actually in shelter before they came to us and started treatment.
Great.
Did I miss anything else?
I'm not sure. Brenda, why don't you type in if there are other things that you wanted Dawn to address, and I'll move on to some other questions. Let's see. There were questions about whether there are plans to make HOPE available in a workbook or curricular format so that therapists or counselors can start to use it, and someone else wanted to know they have a master's level therapist in their shelter, can they get trained on it? So this is like, how can people, if people want to start to use this, how can they do that, or are you waiting? What would be the process for starting to disseminate?
Right.
And would you want to do it with some kind of evaluation criteria? If people started to use it, would you want them to be connected to you, or is it something you're going to put out there that people can just take and use? So maybe talk a little how you're thinking about that.
I mean, that's part of the next step. So as we do this final set of analysis for this last study, we're thinking about, okay, what is the next step, and dissemination would be the next step. As it is now, HOPE actually does have a pretty hefty workbook and therapist manual that's pretty user-friendly. And we do have a training program which was developed for the purpose of training the therapists in the research, which is a 2-day program, about 6 hours each day, 12-hour program. So the materials are available. So the first thing we really want to find out before disseminating is HOPE effective, or because if we find that PCT is just as effective as HOPE, then what we're really saying is good therapy is really useful for this population. It doesn't really matter if it's HOPE or it's PCT, it's that relationship, it's all of those factors. So we want to tease out and find who HOPE works best for so that we know where to disseminate and who to target with the program. So kind of we're holding off doing that until we really have delved into the analysis, and in the next few months we should be at the point where we can move towards dissemination as we finish the analysis. I think if we did disseminate it, when we do disseminate it, that I think it would be important to evaluate it and look at the components and try to see how HOPE needs to be modified in different environments, because although I have been in 8 different shelters, they're still regional, there's still a lot of commonalities amongst them. So I think working together to see how to best incorporate it into specific environments, and then evaluating and seeing, kind of doing the same thing that I've already, like a similar model that I've already used of letting feedback from from women who participate in the program as well as data drive any adaptations that you make for the specific environment. But definitely anyone who's interested, and then, contact me, and once we're at that point where we're disseminating, my contact information is in these slides, and I can follow up and let you know where we go with that and how that's going to work once we get there, and hopefully it will be shortly in the next few months.
Great. So here's an interesting question. Someone asked if any of the women ever come back to volunteer at the shelter or be a support for HOPE participants. It's interesting.
It is an interesting question.
Yeah.
And there was a point in time where I've had contact with HOPE participants where they've come back in training settings where we were training. Before I was at the University of Akron, I was at a trauma-based outpatient clinic, and we did bring back some HOPE participants who do training with residents or some of our students or interns. But I haven't really had them work with HOPE participants, but that was always something I envisioned, especially as I think later through the recovery process, that, and if you look at Worrell and Reamer's model of empowerment therapy and feminist therapy and their model of empowerment, that kind of social activism giving back is part of that process. And so, that's something that I definitely have thought about in the longer term, and but I haven't necessarily done yet. Great.
I know some of the kind of promotor líderes models like Casa de Esperanza and have women have gotten involved after in leadership and community organizing positions as part of post-recovery part of their healing process, and that's been, and I think there's some evidence that that's been really helpful to people. So I'm not seeing more questions. Anyone have any final questions before we turn it back over to Carla? Dawn, do you have any other reflections that you want to share?
I think I think the one thing that kind of has something to do with HOPE and more to do with the research that I've done is that one of the lessons I've learned from doing all this work is that in the research that we did, we were a constant in the women's lives, and they would come in and leave and come in and leave, and we'd lose track of them, and then they'd resurface. And that would happen in therapy, and that would also happen in our follow-up. And I think it's really important to many traditional therapy settings, if someone kind of doesn't show up for 3 sessions, they get discharged or they get kicked out of treatment, and we didn't do that. And we'd have women go away and not schedule with us for a month or 2 months, and then all of a sudden they'd resurface and they'd finish the program. And I think that that's really important to working with this population, is kind of being constant and not punishing them for having other things going on in their life, which is there's so many competing demands we've found for these women, and sometimes they're like, I can't deal with this right now. And then all of a sudden they come in and they're like, thanks for being there still, because now I'm ready. And they come in and they're able to really focus on themselves and participate in HOPE. So I think that's like one of my big take-home from doing this work across the last 15 years.
Thank you for sharing that. I think that's really, really important. And I think that both the consistency and the flexibility and being able to meet survivors where they are, which is tricky when you're doing a randomized controlled trial. So
right.
Finding a way to do that, I think, is really, really important. There is one question about why you didn't work with people who had bipolar disorder diagnoses, and I think you did say that because you thought they might have other needs rather than this treatment program. But
yeah, and I think if they're stable on meds and that they would do fine, but from a safety perspective, doing early clinical trials, we really wanted to make sure that there wasn't anyone who really needed other treatment. So it was more of a really precaution than anything else. But in the real world, I don't know that I would exclude women with bipolar disorder.
Thanks. So if there aren't any other questions or comments or thoughts, Carla, do you want to do the wrap-up? And before you do that, I just want to thank you, Dawn, for really doing a wonderful presentation. And one of the things that I really appreciate about you and your work is how thoughtful you are at every step of the way, and how transparent about what works and what doesn't work, and really trying to think about and understand that, and then take the next step and really figure out what is making a difference for survivors in their lives. So,
well, thanks, Carole. I appreciate that, and I thank so much for having me. It's been great to talk about hope and share with so many people, you know, something that I feel very passionate about.
So, Carla?
Yes. All right. Thank you both again. Thank you, Dawn and Carole, for leading today's webinar. Thank you to Caption Colorado for providing today's captioning, and thank you to Angelica for making the webinar run so smoothly. And last but not least, thank you all for spending your time with the center. Within the next week, we will send a follow-up email with a link to the recording, as well as slides, handouts, and a certificate of attendance for your time today. At the end of the webinar, you will be taken to a very brief evaluation. If you could take a moment to let us know what was useful and what we could have done better, it would be greatly appreciated. So I would like to thank everyone again, and I hope you have a wonderful afternoon.
Hi.